Okay, thank you. Thank you very much, Nathan, for inviting me for this presentation. So today I would be dealing with oxygen therapy in neonates, and with this topic, I have a lot of reservation actually, because oxygen therapy alone has very limited role these days in neonatology. So most often the physiology of respiratory distress in newborns, it's linked with the problem of FRC or functional residual capacity. So they often require some amount of positive and expiratory pressure. So whenever we are dealing with respiratory support in neonatology, the oxygen therapy is the first step. So in any kind of respiratory support, you have to give oxygen, be it non-invasive ventilation, including HFNC or CPAP, be it mechanical ventilation or high frequency ventilation. You always have some FiO2, right? So that's the oxygen. So I would discuss in this presentation about a brief introduction, a few physiological principles which are very important to know whenever we are dealing with the oxygen therapy in newborns, oxygen delivery devices, targets, oxygen monitoring, and a few case-based scenarios. So as we all know, oxygen is a colorless, odorless, and tasteless and transparent gas, slightly heavier than air. Approximately in the room air, we have 21% of oxygen. And it is very important for aerobic metabolism in all the living beings. So why we are worried? Why why we are discussing it, especially in newborns? Oxygen you can give anyhow. You can just start oxygen and it goes. But then, as it is a drug, it should have some dose, and it is not without any side effects. Especially in newborns, where there are several developmental transition going on after the fetal to neonatal transition, and we all are aware that there are a lot of diseases in neonatology which are linked to the oxygen uses, especially the retinopathy of prematurity, bronchopulmonary dysplasia. So we need to know what is the optimal range and what is should be the mode of trans administration while giving oxygen. And we always titrate the oxygen therapy so that the toxicity is less, and we have to optimize the neurodevelopmental outcome, especially with the way we deliver oxygen. So determinants of oxygen delivery are mainly FiO2. So whatever the fraction of FiO oxygen concentration we are delivering in a setup, that is important. Then what is the ventilation? That is what is the baby's respiratory effort, whether the baby is ventilating fine. So ventilation perfusion is ratio is very much important. We all have studied in this physiology. So lung has to be ventilated and lung has to be perfused. So if the lung is not having a good ventilation and perfusion, this will compromise your oxygen delivery. Again, if the baby is in shock by way of decreased cardiac output or heart failure, then again the oxygen delivery would be compromised. If baby is having low hemoglobin, then again the oxygen delivery would be compromised, and there is oxygen dissociation curve at tissue level. So it is not only relevant that we control all this parameter and this is okay. At the tissue level, the delivery of oxygen from the blood to the tissue is dependent on the so many factors, and it is also affected by several factors, including the type of hemoglobin in the baby, the type of whether there is acidosis or not. So we would be discussing this in subsequent slides. So the basics of oxygen delivery, we know that the oxygenation would be depending on the oxygen content of the blood and cardiac output. So the oxygen is supplied through the blood vessel via blood. The blood carries the oxygen to the tissues by way of the heart, pumping of the heart, which is cardiac output. And in the blood which the heart pumps, there is some oxygen content. Then oxygen content is again determined by the oxygen which is bound to hemoglobin in form of HbO2 plus dissolved oxygen. Normally, a very small amount of oxygen is dissolved in the blood, and most of the oxygenation is dependent on the hemoglobin, which oxygen which is bound to the hemoglobin. So this is the formula for the calculation of the oxygen content in the blood. And for that matter, you know that you need to know the what is the saturation of the baby and what is the PaO2 content, which would be determined by the RDL blood gas report. Then we need to know that the oxygen dissociation curve is the Singh model curve, and which we would be discussing in the next slide. So this is the oxygen dissociation curve, and it is very relevant for the discussion that in the middle part, that is approximately 20 to 50 PaO2 level, the saturation goes very fast. The change in the saturation is, this curve is very steep. So a small amount of increase in the PaO2 changes varies the SpO2 very fast. First, why we are discussing this? Because after, you can see that after a PaO2 of 60, this curve is plateaued. That means we have SpO2 on the y-axis and the PaO2 on the x-axis. So the SpO2 is dependent variable on the PaO2. So if the PaO2 content is more than 60 or more than 70, your saturation doesn't changes much. That means from approximately 90 to 100% oxygen saturation, the PaO2 can be anything. So why it is important? Because this PaO2 is again determining the hyperoxia at the tissue level and its long-term toxicity. So this oxygen dissociation curve is very relevant for the understanding of why hyperoxia occurs, even with a slight within a range of the 90 to 100%. The PaO2 can be anything, and you don't know what is the tissue are exposed to the oxygen level. Then what are the condition which determine the delivery of oxygen to the tissues? So in this oxygen dissociation curve shifts to the right whenever there is acidosis, there is hypercarbia or hyperthermia or adult hemoglobin. This shifts to the left whenever there is hypothermia, hypocarbia, alkalosis, or decreased 2,3-DPG or fetal hemoglobin. So we again go back to this curve. Shifting of the right means the delivery of this line shift to the x-axis, and to the left means this line shift towards the y-axis. So the delivery would be more if there is acidosis, if there is adult hemoglobin, and if the delivery is less, if there is a fetal hemoglobin or alkalosis. So the fetal hemoglobin is tightly bound to the oxygen level, oxygen in the baby, and the delivery is lesser in case of the fetal hemoglobin. This explains why the newborn is the fetus is well maintained in a low PaO2 levels in utero. So the postnatal oxygenation is highly dependent on the gestation age, type of the delivery, and whether the baby is breathing spontaneously or requiring some amount of respiratory support. The fetal PaO2 is physiological fetal PaO2 is very less, around 25 to 35. In the pulmonary circulation, the oxygen level is 17 to 19, and it also depends on a maternal oxygenation level. So in the perinatal care, after the cord clamping, the PaO2 increases to 65 to 75 within 5 to 10 minutes. And it is the physiological oxidative stress which leads to the postnatal adaptation. In the pediatric or adult, the PaO2, normal PaO2 is taken as around 80 to 100, but in the neonatal, it is around 70 to 90. So the next, coming to the what is the normal oxygen saturation nomogram? So what should be the normal oxygen saturation depending on the gestation age and birth weight, and there are a lot of nomograms in neonatology. So oxygenation is something which changes after birth. It has a lot of physiological transition. It depends on the it is affected by the prematurity, and it is also affected by the presence or absence of ductus arteriosus in the neonates. So a lot of studies has been tried to look for the oxygenation nomograms, though the evidence is still lacking, but then we have oxygen saturation nomogram given by the Dawson. They studied the oxygen saturation level in 468 newborns around 25 to 48 2 weeks of gestation, and gave the centiles of the oxygen saturation. So these are the oxygen saturation centiles. This is for the all newborn. This is for the more than 37 weeks, and this is for the 32 to 32 to 36 weeks and less than 32 weeks. So we should avoid oxygen saturation level less than 10 percentile or more than 90 percentile. So what are the indication of oxygen delivery? Of course, when there is a central cyanosis, clinically, when there is a hypoxemia or oxygen saturation of less than 87% or PaO2 of less than 50 on room air. And If there is a presence of respiratory distress irrespective of oxygen saturation, we need to give it. So coming to the sources of oxygen delivery, it can, so we all work in the hospital setup and we all know from where it comes. So whenever you are doing a transport or transition kind of thing, there is an oxygen cylinder which is there. We all know about oxygen concentrator by virtue of COVID. So the oxygen concentration are mostly can not give very high flow oxygen, but then they can provide up to 5 to 8 liters maximum with a FiO2 range of 90 to 92%. They are very good for the home therapy of oxygen. And the most common one with advanced respiratory support is the wall-mounted oxygen source. So it is in the central supply. There is a wall-mounted source in which you put the oxygen flow meter and you deliver the oxygen through that. So sources of oxygen delivery, when we are discussing, this is important that this is the flow meter is very much important. So flow meter, this kind of flow meter is usually attached to the oxygen cylinders, which indicates the pressure in the oxygen cylinder, and you can regulate the flow via this knob. These are the oxygen outlet ports, flow meter ports, which are attached to the wall-mounted oxygen supply system. And you can see this is the below this is the glass container. So one important point I wanted to emphasize here is that you should not put any water in these flow meters because this water doesn't serve any purpose, and it is a common source for the contamination and growth of the bacteria. So this used to be a very common practice previously to put the water in this and change the water every day, but then this doesn't serve any purpose, so it should not be done. So coming to the devices which are used for oxygen delivery, there are a lot of oxygen devices delivery devices in pediatrics, but in the neonatology there are few. I would be discussing mostly all the oxygen delivery devices and would emphasize on those which are relevant to the neonatology practice. So the oxygen delivery devices would include nasal cannula or nasopharyngeal cannula, nasal prongs, which can be uni or binasal, nasopharyngeal tubes, nasal mask, or oxygen hood. Then again, in case of advanced setup, it can be delivered through the laryngeal mask airway, endotracheal tube, TB resuscitator, or incubators also. So the classification of oxygen delivery devices is mostly based on the low flow devices or high flow. And low flow devices are the devices which has variable performance. Their oxygen delivery by these devices are not very fixed and they are variable. While in the high flow system, it is fixed and precise oxygen delivery can be done. The flow is meant by virtue of the inspiratory effort of the baby. So in the case of low flow devices, the important one are nasal cannula, intranasal catheter, simple face mask, partial rebreathing mask, and non-breathing mask. In the high flow devices, we have oxyhood, venturi system, face tent, oxygen tent, and high flow nasal prongs. We would discuss one by one. So the low flow oxygen delivery devices have advantages that feeding and KMC is easier. They have less risk of displacement or CO2 retention. They are preferred for home therapy. The disadvantages include it can irritate to the nasal septum, or it can lead to crusting or septal trauma erosion or inadvertent PEEP delivery. In the case of high flow devices, they provide a higher FiO2. Whenever there is a high FiO2 need, they should be used. They deliver a specific FiO2 greater than inspiratory flow, and they are very well tolerated. They have no risk of gastric distension or airway obstruction. But there is disadvantage of the CO2 retention if the flow is kept low. So coming to the nasal cannula, its flow is usually kept as 1 to 2 liters per minute. In the nasopharynx, oxygen is reservoir and FiO2 is around 25 to 45%. In the nasopharyngeal cannula, the length is measured as alinesi to tragus, and fluid is again low, 1 to 2 liters per minute, and FiO2 range is 25 to 45%. And so it's with the nasal prongs. In case of oxygen hood, high flow devices oxygen hood, the FiO2 depends on the flow rate, size of the hood, and side ports. If you close one side port, the FiO2 is around 40 to 50%. if both ports are open, it is 30 to 40%, and if both ports are closed, it is around 80 to 90%. We will see it, and the flow rate is usually more than 5 liters. And the incubator system requires very high flow, and these are less often used. So coming to the low flow devices, this is the nasopharyngeal prongs, which the measurement is depicted in this diagram, which you can measure from the LNSI to the tragus for the length measurement, and it has to be inserted and fixed for the oxygen delivery. For the simple nasal prongs, these are two soft nasal prongs attached to the oxygen tubing, a flow rate of around 0.25 to 4 liters per minute, and nasopharynx act as a reservoir for oxygenation. Rates more than 2 liters is mostly indicated for the humidification in pediatric age group. But however, the National Neonatology Forum guidelines suggest in the newborns, even more than 1 liters flow requires humidification. When you increase a flow of more than 6 liters per minute, there is no advantage of increasing FiO2, and it can lead to a lot of irritation. So with the low flow devices, the flow are usually less. This is a chart which can show that with what flow approximate FiO2 delivery correlation. So with the 1 liter approximate oxygen delivery 24%, with this 6 liter it is up to 45%. Mostly it is prudent to use up to 2 liters, 2 to 3 liters in the newborns. Then this simple face mask, it would be less often used in neonates, but can be used in young infants or pediatric age group. This is the simple plastic face mask with two side ports. It doesn't have any valves, and it has a flow rate of around 5 to 8 liters per minute. Minimum flow rate should be 5 liters per minute, and a flow rate of more than 8 liters per minute doesn't provide any advantage in terms of increasing FiO2. So this is the chart for the requirement of the deliver FiO2 as per the flow rate. Then a few low flow devices which are very important for the pediatric age group includes partial rebreathing mask and non-rebreathing mask. So they deliver the FiO2 of more than 62%, or in case of non-breathing mask, it is up to 80% also. And it has a reservoir bag in which there is mixing of the oxygen and with the exhaled air, and it gives around 60 to 80% of oxygen. In case of a non-breathing mask, up to 80 to 90% oxygenation can be delivered. Coming to the high flow devices, this is the oxygen hood, which is the one of the common, very common delivery device in neonatology, and it can be placed over baby's head. So there are side ports on the sides which can be closed to adjust the FiO2 levels. So it should be up to more than 5 liters per minute. If it is not so, it can lead to CO2 retention. The sizes are as per the baby's weight, and they come in the category of a small, medium, and large. These are the another high flow devices, which are the Venturi system. So the Venturi system gives high flow and fixed performance. It contains one jet, and this has two entrainment ports. So Venturi mask, by virtue of air entrainment and Bernoulli's principle, provides a very high FiO2 requirement, and there are color-coded Venturi connections which give the different FiO2s. So these are also important ones which are used in pediatrics. Then one more high flow device is incubator. So incubator, you all must be aware, are used in neonatology for the care of preterm babies. As such, the preterm babies often have a problem of FRC, and they hardly would be given as such simple oxygen therapy. But sometimes if a case of BPT is there who requires a very minimal oxygen, around 21 to 23%, the incubators have connection of oxygen and air port with inbuilt blender system, which can be attached to the wall mounted system, and they have a display in which oxygen can be set for the FiO2 level, and it would be delivered inside. This presentation is not intended to discuss about high flow nasal cannula or other non-invasive devices, but just to mention that whenever there is a high flow of oxygen being given, it should be humidified and heated. And HHFNC mostly provide a flow of more than 2 liters in neonatology. and FiO2 range of maybe 21 to 100%, they provide some amount of positive end expiratory pressure. So this is the one of the common interface or high flow nasal cannula which is used in neonates. And depending on the size or numbers, you have the flow rates, and as per the premature and infant age group, they are color coded. Bubble CPAP system gave a precise PEEP delivery along with the blended oxygenation and humidified. So,
Ma'am, you can talk a bit more about those if you feel like. I mean, we will take the talk on non-invasive and PEEP-related, pressure-related usage in the next presentation. You can, if you want, you can elaborate more, ma'am.
regarding what, HFNC or bubble CPAP?
Yes, ma'am. Yes, ma'am.
Okay. So, regarding high flow nasal cannula, we talked of nasal cannulas in the oxygen, simple nasal prongs or simple oxygen prongs. So, important point is the heated humidified high flow nasal cannula system is that it has to be heated, it has to be humidified, and it has to be high flow. So, the three H has to be understood whenever we have to understand the principle of HHFNC. So for the HHFNC, this diameter of the nasal cannula is very much important, that this should be such that it should occlude around 50% of the nasal aperture of the baby in which it has to be placed. So why this 50% is there? Because you have to give up a way for exhalation of gases. There is, in case of CPAP, we would be discussing that there is an exhalation limb. While this is not so in case of heated humidified high flow nasal cannula system. So the inspiratory gas goes through this nasal prongs, and exhalation has to occur by side of this nasal prongs. So this has to occlude up to 50% of the nasal aperture for the HHFNC, and that's why there is a leak. And we in this HHFNC system, there is no precise PEEP delivery, though there is some PEEP deliveries there. In case of bubble CPAP, you can see there are two limbs. There is a humidifier, there is a blending mechanism. This is a blender from which blended gas comes to this port, and it gets the humidified and heated via humidifier. And with this blue limb, it goes to the babies. And with this white one, this goes to the expiration. Exhalation port is fixed to the underwater seal water container, in which by altering the depth of this tube, we can provide the positive and expiratory pressure and adjust the level of PEEP in case of bubble CPAP. While in case of ventilator CPAP, it is controlled by the inbuilt mechanism inside the exhalation part of the ventilator. In case of this nasal interface, I have not kept the images, but important point here to highlight is that even if the nasal prongs are also used for as an interface in the bubble CPAP, which should be snugly fitted for the PEEP delivery. So the difference between the choosing of the size of the bubble CPAP and HHFNC is that you have to have snugly fitting nasal prongs or mask, which should occlude the nose completely to provide the precise and accurate PEEP delivery in case of bubble CPAP, while in case of HHFNC, it has to be loose. So coming to the blenders. So blender, what are the blenders? Blenders means the literal meaning of blender is mixing. So why we want mixing? Because we don't want a oxygen which has to be given unregulated. So you from 21% to 100% oxygen delivery, you need to have some mixing of air so that your oxygen concentration has to be regulated. So the blenders are the devices which provide a precise FiO2. It has to be, this is the standalone blender. Otherwise, blender is always there in case of CPAP machines, in case of HHFLC, and of course in ventilators. So you always have blenders inside the ventilator, inside the CPAP, and also in HHFNC. While you can also have standalone blenders, which has this kind of setup. This device can be fixed to the wall, the stand, and you can see these two metallic tubes which are coming out. They are attached to the wall-mounted air and oxygen outlet from the wall-mounted system of the gas supply. Often these contain two flow meters. There is one low flow meter and there is one high flow meter. The low flow meter usually goes from 0.1 to 2 in this, and the high flow goes up to 15 liters per minute. So from this you can have, from the center you can have an from this the flow meters you can have oxygen tubings which can be attached to the distal interface at the baby's level, and you can adjust from 21 to 100% oxygen delivery here by way of blenders. So blenders are very much important in neonatology and which are often overlooked by whenever someone is uh, having a setup of the NICU, and they are not, and you should know that if you have blenders and if you have humidifiers, just by changing the tubes, having the CPAP circuit or the high flow circuit, you can give high flow therapy, you can give CPAP therapy by having the blender and humidifier. So these are the two things which are important. Rest of the things are disposable in any kind of bubble CPAP and HHFNC devices. So the blenders have to be attached to the wall mounted air and oxygen port, and the two flow meters are there. So the precise FiO2 delivery cannot be imagined without blenders. Then this is something which was previously very much used, as people were aware that the oxygen toxicity can lead to the problems. And this is a chart which can provide you about the blending. So suppose if you don't have a blender, but then you have a oxygen and air flow meters which are attached to the wall mounted source, and you connect those oxygen and air to a Y piece and put it to the baby, then by altering the flow of oxygen and air flow meters, you can adjust the FiO2. Suppose if you choose a 4 liters oxygen flow and 4 liters air flow, you are going to give a FiO2 of 60%. If you choose a 3 liters of oxygen flow and 5 liters, 3 liters of air flow and 5 liters of oxygen flow, you are going to give a FiO2 of 71%. So this is the chart which can provide you a rough estimate of that how much FiO2 you are going to deliver by blending of the two board system. Even if you don't have a blender, you can do some adjustment by connecting to the Y port and providing it to the baby. So oxygen saturation targets. This is a very interesting topic which has been studied over the years and years and years, and it is always it was always debatable that what is the good oxygen saturation for the baby. Initially, it was in the uh, before this 2000, it was thought that high oxygen delivery is good, and subsequently it was observed that no, then oxygen is toxic. It leads to the problem with the retinopathy of prematurity, and also it is not very good. The resuscitation, a brief exposure to high oxygen level in resuscitation is also detrimental. So just to understand that what should be the oxygen targets during neonatal resuscitation. So this is the blender which we just discussed, which in all the delivery room you should have blender, because if you have to have a precise FiO2 delivery in case if required, you should give it through the blender. Then what should be the oxygen saturation? So it is important that this chart, this 1 to 10 minutes oxygen saturation target chart should be there in all the delivery room. And over the time, over the 2-3 months, the most of the people who daily go to the delivery room memorize it, and they by heart learned it that from 1 minute it is 60 to 65%, and at 10 minutes it is 85 to 95%. The goal is SpO2 of more than 80% by 50 minutes. So you should have a pulse oximeter which should be attached to the right wrist of the baby. You should have a blender. You should start your resuscitation by adjusting a flow up to 10 liters and FiO2 of 21% for the babies who are term, but from 21 to 30% if the baby is less than 35 weeks of gestation. So initial resuscitation with 21 to 30% for the moderate preterm, while 21% in case of term delivery. If we have to have a CPR during resuscitation, you have to change the FiO2 to 100%. And even if in the neonatal setup, suppose if the baby has requires resuscitation and have ALT in the while being nursed in the neonatology, So after return of spontaneous circulation, you should wean to 21% in case of term babies who have no lung disease, and up to 30 to 40% in case of preterm baby, depending on the SpO2 targets. Post resuscitation care, after 10 minutes, the oxygen saturation target should be 90 to 94%. Then again, while routine care of the routine neonatal care, what should be the target? So now it is pretty clear that it has to be 90 to 95%. So that's why the oxygen saturation alarm limits are around 88% for the lower limits and more than 95% for the higher limit. A few case of PPHN, some up to 97% of oxygen. In case of whenever some baby is having persistent pulmonary hypertension, the oxygen saturation should be targeted towards higher side and can be targeted up to 97%. So this is about the oxygen saturation targets. One should always avoid the hyperoxemia more than 98% in the routine neonatal care or even in the delivery room. So how to assess the oxygenation? So assessment of oxygenation requires the clinical assessment. So the clinical assessment include the visual assessment. So visual assessment may be difficult in the baby who are having dark skin. And this is shown here in this diagram that with the similar kind of SpO2, the PaO2 can be less in case of the darker pigmented baby and can be more in case of the fair baby. So they can be fallacious. So visual estimation can not be very accurate. Then SpO2 is often measured by the pulse oximeters, and one should choose a pulse oximeter which has a good accuracy and which can have a good signal extraction technologies like Masimo. And the PaO2 is determined by the indwelling arterial catheter or umbilical artery catheter. So the sampling for the estimation of PaO2, one has to have a sample from the arterial line, which in the neonatology can be either umbilical arterial line or peripheral arterial line, or sometimes in case of cardiac surgeries, the femoral artery line are also put for some time in early invasive, post-operative invasive monitoring. And a P by F ratio is the assessment of the oxygenation and depending on the whatever FiO2 is being delivered. So a few suggested practices which should be very relevant for the low and middle income countries. So what has been the common practices? Mostly that the oxygen was mostly given by the cylinders without any blenders, or this wall mounted flow meter is directly attached to the baby. Then pulse oxygen, so often it is observed that baby is on oxygen, but there is no routine, baby is not continuously being monitored on pulse oximeter. So whenever a baby is being delivered a oxygenation level, supplemental oxygen or any respiratory support, baby should be on continuous pulse oximeter monitoring. There is nothing such that it should not be compromised upon intermittent pulse oximeter monitoring. So in this left side of the slide, we can see that giving oxygen through the cylinders without proper blending mechanism, or giving oxygen through the wall-mounted oxygen source without blender and unregulated oxygen, and not having a proper monitoring are the problems which can lead to the disease of the oxidant injury, which are BPD and RP. So the suggested intervention which can improve the oxygen blending include blenders, which can be given by CPAP or ventilator or oxygen blender as such, which we discussed. And some Venturi device which can titrate the precise FiO2. This is the Y connection which I was talking about. That this is the one of the oxygen flow meter, and this is one of the air flow meter. You connect both. You set the flows 4, 3, 4, 4, 3, 5, 2, 6, and subsequently by the chart you can adjust that whatever your FiO2 is delivered. And subsequently, in case of high SpO2 or low SpO2, you can adjust the flows and titrate the FiO2. And of course, the continuous pulse oximetry monitoring cannot be overemphasized. So just a few cases. Actually, this oxygen therapy and the key points are quite obvious, but then just to highlight a few cases. So this is a term baby which is delivered by elective LSCS and have tachypnea with Downey score of 3. with SpO2 of 86% and respiratory rate of 80 breaths per minute. So what should be the saturation target? So, and the question is that what is the choice of oxygen delivery device and what is saturation target and what should be the flow of oxygen? So I think uh, it can be put in the chat box regarding the answers. Okay, so the choice of the oxygen delivery devices can be oxygen by hood or simple nasal prongs. The saturation target, again, in the routine neonatal care, it remains 90 to 95%. And the flow of oxygen should be if you are using hood, then it should not be less than 5 liters per minute. If you are using oxygen by nasal prongs, it should be up to 1 to 2 liters per minute. But then again, if it is more than 2 liters, you have to take care of the heating and humidification. The another case is that a baby who is born by vaginal delivery at 38 weeks of gestation is having cyanosis at 30 minutes of life, obvious cyanosis. And baby is not having any respiratory distress and SpO2 of 72% with respiratory rate of 64 per minute, and there is no retractions. So what should be the choice of oxygen delivery device in this case, and what should be the saturation target, and what should be the flow of oxygen? So yes, so this is hood. This can be given by hood or okay. So this baby is this with this clinical presentation. It seems that this baby is not having any workup breathing, but then it is having a such cyanosis, and which is confirmed by the SpO2 of 72%. So this looks like a case of cyanotic heart disease. Most of the cyanotic heart disease would have some respiratory distress. A few can have like non-obstructed TAPVC can have even no respiratory distress. So they can be given a supplemental oxygen and oxygen saturation targets in case of the cyanotic heart disease for the usual care maybe up to more than 70, more than 80%. So the another case, a term baby delivered by emergency LSES have tachypnea with Downey score of 6, with SpO2 of 80%, respiratory rate of 96 beats per minute, and at 48 hours of life, there is a history of meconium stent liquor and saturations are labile. So the what is of choice of stent delivery device? So in this particular case, of course, with the Downey score of 6, this baby again obviously requires advanced respiratory support in form of intubation and ventilation. And this case has been put because to emphasize that this baby is likely to have all the risk factors for the having a persistent pulmonary hypertension with a lability of saturation and history of meconium stent liquor. So this saturation target should be more towards, as I said, that is up to 97%. Uh, this is the important case. This case we just had in 2 weeks back. So this is a term baby who presented at day 20 of life with history of cyanosis since birth. There is no respiratory distress, but baby was very irritable when the baby presented to us. So this was the color of the baby. The baby looked blue and dusky in color. I would just run this video and you can see the video in details. You can see the saturation is 93%. So what is the case? Yes, somebody said methemoglobinemia. ABG showed a high PaO2 levels. So in case of methemoglobinemia, the saturation is mostly towards lower side, around 80 to 90%, and PaO2 is obviously normal to very high. This video, I think it may not be visible in this video, but it is showing a red colored highlight of methemoglobin level. So this we have a Masimo co-oximeter which showed a methemoglobin level of 63% in this baby on co-oximetry. And of course, this baby also had a blood gas value in which also we have methemoglobin facility. So it again showed the same concentration. After giving methylene blue, the methemoglobin level was 1.5% in this particular baby, and baby became pink. So you have been called to attend the delivery of a baby at 38 weeks of gestation. So what should be the flow of oxygen or blended gas, and what should be the FiO2 to start with? So in case of normal term delivery, it should be done on the room air resuscitation. More than 35 weeks of gestation, the resuscitation should be started with the 21%. And the flow, if required, the flow should be set at 10 liters in the blender. And if the you have to attend the delivery of a baby who is 31 weeks POG, the FiO2 start should be 21 to 30%, and subsequent titration should be according to the uh, SpO2 level. So while performing CPR in delivery room, one has to have 100% of FiO2. So a few words about the pulse oximeter. So as per the NF-CPG recommendation, it is said that any pulse oximeter which have a signal extraction technology. Signal extraction technology are various. It includes most commonly and most widely popularized in the neonates is Masimo, and all the pulse oximetry based screening, congenital heart screening guidelines also recommend the Masimo technology. So it is a kind of set technology or signal extraction technology. The other signal extraction technology are also good. In case of Philips machines, it is the fast and others. So this is the the brand should have a good signal extraction technology, which should be taken care, and while deciding about a pulse oximeter. And uh, these monitors should also be taken care, like should have a good accuracy of around 1 to 2% for the saturation estimation, and averaging time should be less, and they should be able to detect the oxygenation in low perfusion states and takes care of motion artifacts. So the case of methemoglobinemia, which what we observed that there was the pulse oximeter was showing also a methemoglobin level monitoring. So it is a non-invasive way to monitor the methemoglobin level, and there are the co-oximeter from the Masimo, which can give you a real-time continuous display of methemoglobin levels. They can also give you a carboxy hemoglobin level or sulfa-methoxy hemoglobin level by use of special sensors. So that can be possible. So I would conclude the presentation with the points that oxygen therapy should balance the tissue oxygen delivery, preventing both hypoxia and toxicity. So the aim should not be that baby should not be hypoxic and there should not be hyperoxia. The initial oxygen for resuscitation varies from 21%, that is room air in term baby, and 21 to 30% or higher in babies less than 35 weeks of gestation. A preductal SpO2 of 90 to 97% in case of uh, PPHN, as it help in lowering the pulmonary vascular resistance. And lack of oxygen blenders increases the risk of hyperoxia. So blenders are something which should be invested upon. One should understand the importance of blenders. And if you have blenders and humidifiers, you can give very well the HHFNC and CPAP therapy, which is key to the non-invasive respiratory support in the neonatology. And if we talk of the perinatology, maternal SpO2 of more than 95% ensures adequate oxygenation to the fetus. So whenever there is a mother with a chronic cardiorespiratory disease, the aim should be have a maternal SpO2 level of more than 95% while the mother is having a perinatal or antenatal care. Thank you. If there are questions, I would be happy to take those.
Yes, ma'am. Thank you, ma'am, for your presentation. And again, it's a heartfelt gratitude from my side that a lot of new points on one of the topic which is very close to every clinician's mind, heart, soul, body, and work. But still, we learn everything new from pioneers like you, ma'am. Dr. Rajesh Kulkarni is asking, and in fact, in your talk, you have mentioned that it is advised not to put any water in the flow meter, which are wall mounted. So,
Yeah.
just as a comment or as a question, if we have any evidence which is relevant to be shared, or is it the experience of institute which you are sharing? Kindly shed some light on that, ma'am.
The water level, this is the there is a like this is the module from the NeoQuip called as NeoQuip in the NNF, and this was discussed that there are some practices like what we are going to get while we put the water in this chamber. If you put water in the chamber, the only thing is that you can see the bubbling, but then that can be otherwise seen also, and this leads to an important task in the nursery that some attendant has to change the daily water. If it is not changed, it can lead to contamination and growth of the bacteria or fungus. So that's why it doesn't help much. So that's why this practice should go away. That is what is that, and it is recommended by NNF. That is what I can say about that.
Second question is by Dr. Sunil Reddy. His question is, isn't hood obsolete now?
Yes, definitely. Actually, when you told me to this talk about this oxygen therapy in the unit, so I just told at the outset that oxygen standalone in neonatology has not very much role. I would say that uh, in fact, in our nursery also we are not using it. But sometimes, like that methemoglobinemia where baby when the baby was having a methemoglobin of 63% and was irritable, it is recommended to give a supplemental oxygen to that baby. In case of baby who are cyanotic heart disease and not having very significant respiratory distress and Downey score of less than 2 or up to 2, then that kind of baby can be given. But again, I really agree with the point that this should not the use of oxygen hood should be discouraged, and one should understand the physiology of respiratory distress. So in the neonatology, it is respiratory support, and it is the bottom most strategy for the uh, use of it is the first step in case of respiratory distress which has to begin. So it only tachypnea, if there is only tachypnea without retraction, only where and cyanosis, only where oxygen can help by hood. Otherwise, in case of any retraction, you have to give PEEP by way of bronze, by way of CPAP or something. So I agree with the fact that hood is obsolete, but then as we are discussing oxygen delivery devices, so just kept it. For sometimes it can be helpful in case of a baby who is infant for a short period of time. But again, this point is well taken.
Dr. Girish asks that why oxygen is recommended when respiratory distress is there, but saturation is normal.
So oxygen, yes. While discussing the indication, it was said that oxygen should be given if irrespective of if there is respiratory distress. So again, this point is again important for the pediatric age group and can be taken away from the neonates. So this can be taken care for the infants and pediatric, but not for the infant. Respiratory
And
distress is there, then you have to provide the P.
a question by Dr. Sunil Reddy is, which is better, bubble CPAP or HHFNC?
This is a very debatable thing. I would just
And a broader
give,
topic also, which we will take in
yes.
future sessions.
So HHFNC and CPAP. So again, in case of the primary respiratory distress, while say telling the primary respiratory distress, I mean the respiratory distress, which is respiratory distress syndrome presenting within the first few days of life. When just after birth, you have to give respiratory support. CPAP is better as it provides adequate PEEP and precise PEEP delivery. For the post-extubation support, both are fairly comparable. HHFNC and CPAP both are comparable. So in case of primary respiratory support, one should prefer the CPAP.
Dr. Shravan asked the brand name of the monitor which you had.
That is a Massimo pulse oximeter, Radical 7.
A
But
question asked by Dr. Ramakrishna.
yeah, in case of pulse oximeter, I would not say that it is a must kind of thing and you should invest heavily, because the Massimo technology is often the Massimo monitors, which are the bipara monitors. By virtue of bipara means that these are the monitors which have SpO2 and a heart rate facility. So they are often overpriced. when you can get a normal pulse oximeter in very well in 1.25 lakhs, they would charge you around 4 to 5 lakhs, especially in institutes. But then you should take care of the technology. So as I said, that there are various signal extraction technology. The signal extraction technology with the Philips, with the Nihon Codin are also good. So Masimo is something which has been popularized in the neonatology. So one can just take care that they are using some good signal extraction technology, and that monitor can be used. The monitor which I showed was important for the co-oximetry because of the methemoglobinemia case. Otherwise, it is not must. So another important thing is that lot of multi-para monitors also have the facility of Masimo technology. So a lot of machines like Mindray can they purchase the technology from the Masimo and provide you the module of the SpO2, which provide you Masimo monitoring of the saturation. So that is the thing. We can go to the next question.
What is the increased risk of ROP in preterm with usage of high flow device?
So it is not the high flow device, it is the saturation target which is troubling. So the problem is not with the high flow, the problem with the saturation. So you have to monitor the saturation. If your saturation are more than 95%, then there is the risk of retinopathy or prematurity. It is not related to device. Again, I would say it is not related to FiO2. It is the FiO2 may be required for the baby with by virtue of having a significant respiratory disease. Baby is having hypoxic respiratory failure. You are requiring high FiO2. But your saturation, you should not aim the saturation which is more than 95%. That is the key. So that is the difference. It doesn't matter high flow or high frequency or ventilation. It is the SpO2 which should not be going up more than 95%. So that has to be monitored.
What is the target saturation that is to be maintained in preterm?
Again, 90 to 95%.
Should we directly use nasal HHFNC even if there is mild respiratory distress with Downey of 3?
Yes, Downey score of 3 is an indication for the use of high flow HHF. As there was a comment from Dr. Reddy that oxygen hood is obsolete. So the first step is the HHFNC. So you have to use it.
How should we humidify oxygen, ma'am, if we don't put water in the flow?
So thank you for this question. Actually, the water is not meant for humidification. So the water which is kept in this flow meter water container is not humidifying your oxygen. Oxygen, the gas, again, I would say not oxygen, the blended gas which has to go to the baby would only be humidified by humidifier, not through but you if you are asking about that, you have to give the simple blended oxygen therapy and you have to humidify it, then you can put your oxygen tubing to the humidifier port and you can again humidify it can be done. It is commonly done in the adults also, so it is done. HHFNC is almost same which you are asking about, that how you would humidify the oxygen. By putting the water, it is not humidifying this. This is a misconception that this water is humidifying that oxygen. That is not so.
Ma'am, please mention conditions in which HFNC is most indicated.
Age most indicated. So so again, whenever you have to understand that whenever you are providing the any kind of respiratory support, the condition or the disease etiology is not important. The magnitude of respiratory distress is important. So if the respiratory distress is mild to moderate with a Downey score of up to 4 to 5, you can use HHFNC and CPAP. So it is based on the respiratory distress scoring, which includes the retractions, which includes the supplemental oxygen FiO2 requirement, which includes the granting. So these are important. The underlying respiratory etiology is not important.
Ma'am, what about delayed adaptation and weaning strategies by saturation of oxygen?
Pardon, I couldn't understand. Delayed adaptation in?
Delayed adaptation and weaning strategies when we consider SpO2 requirement of the child. How do we wean the child from oxygen in neonatology?
Weaning. Okay. So I would say that Probably you are asking about the BPD cases. So these kind of cases are mostly, in my understanding, in our unit, what we see that most of it they would be requiring a FiO2 of up to 25% with the flow of 2 liters or 3 liters per minute with HHFLC, and uh, they have intermittent hypoxemia. So first step to you have to decrease the, you have to see that flow is less than 30% or 20 up to 25%, that is point FiO2 of 0.25. Then you have to decrease the flow, and one you are at the flow of less than one up to 1 liters per minute, you can try putting the baby off respiratory support for 15 to 30 minutes and see whether there is a worsening of the respiratory distress in form of increase in retractions or desaturation. So by that way, you can see every once you find that the baby has been remained fairly stable for last 3 4 days.
Dr. Rajesh has put it a comment saying that when we consider cost of HFNC and CPAP, we can start on headbox initially and see the response, especially term neonates, and then switch to CPAP and HFNC if no improvement. This
No,
is
no,
taking
no.
consideration of the cost.
No. I, as I would say that that's very that would work in very few cases, and most often you would be needing a amount of PEEP. So cost of HHMC, as I again said, that how to cut the cost is very much important. So if you put the baby on oxygen hood and baby is still symptomatic for 5 days, and if you put the baby on HHFNC, his baby is coming out in 1 day. So which cost is more? HHFNC of 1 day or 2 days by, or a hood of 5 days or 7 days, and again you are giving a high oxygen level on that with by providing the oxygen support by hood. So it is not so. As in the neonatology, all the respiratory diseases has problem of FRC and some retraction. So you would be encountering very less cases which have only tachypnea and no retractions, which would be helped by oxygen. Oxygen is just helping you to increase the SpO2 level. It is not helping you to recover the baby from disease. Baby would recover only when you provide the baby some amount of PEEP, which can be done by HHFNC or CPAP as per the respiratory condition. None of the retraction is going to improve by giving supplemental oxygen. So if you have to hit the retraction or grunting, you have to provide PEEP. So that is very much important. So if the thinking that by providing the support by hood we are cutting down the cost, it's probably not correct if you think logically. And as I said, invest on blenders, invest on humidifiers, that they are not costly. The the compilation of the machines by the brands is costly. You go to the buy FNP, CPAP or Airvo2, they would cost you around 4 to 5 lakhs. If you invest in the blender and humidifier, it would be coming in around 2.5 lakhs. And then you have to just look for the circuits. So the bubble CPAP assembly or the this like HHFNC assembly. In fact, the bubble CPAP assembly can be converted to HHFNC assembly. So if you have bubble CPAP circuit, you can use the same circuit for the HHFNC delivery, but just by changing the HHFNC cannula. So by this, the cost can be cut down. That is my take.
Good one, ma'am. I think the answer to that mystery is to deliver the oxygen efficiently. If need of hour is retraction and grunting, think about adding pressure to oxygen delivery. That will solve the problem. Going ahead with the next question, ma'am. Ma'am, what is the
Yes.
accuracy and experience of delivering HHFNC with dual limb SLE 6000?
With
Dual
with
limb SLE 6000.
I have not used it, but then all the machines work same as per
Absolutely.
my
Science
understanding.
remains the same. Yeah.
Yeah.
So, ma'am, we're going to next question. Downey, Silverman, Anderson score. ABG should be taken into which of the scores should be taken into consideration way in context to ABG before considering the type of oxygen delivery device or utilizing the pressure delivery device.
I don't think Downey's or SAS score have ABG in their component. So ABG is not meant for their. If you have to evaluate the Downey or SAS score, you need to clinically assess the baby and see whether by delivering what FiO2 the SpO2 is maintained or not. I don't think there is any ABG in that.
Okay.
Or I may not have understood the question.
Actually, the question is probably that out of these three scores, which is the most relevant score to decide the type of oxygen delivery? In toto, if we have invisibly done the ABG, will these scores and ABG help us in making this decision? Probably Dr. Rajesh, if I have not done the correct question, kindly edit
Yes, a
the question
Downey
again.
SAS score, ABG should be taken into consideration before. No, I don't think so. ABG should be taken. You can very well do the clinical scoring and both
Proceed with the
work
decision.
fine. Yeah.
I think Dr. Konda has asked the practical question that patient will ask why water is not kept in the emergency department flow meter devices.
So you
So
have
we
to
have to
explain
train the
the
patient.
patient that it can create the infection and that could be harm your baby. So that's why we are not doing it. That's can, and you can say that look, we are monitoring the baby to continuously and it is showing normal oxygen. So don't worry for that water.
Okay. Uh,
What I would like to tell you that if all the doctors say the same thing, then there is a change in practice. If 5 people would say कि पानी डालना चाहिए and 2 लोग कहेंगे कि पानी नहीं डालना चाहिए, तो वो and mostly मुझे लगता है कि there would be very few people who would be asking that पानी क्यों नहीं डाला. मतलब I think they can be explained and they would agree with that if they are patients, parent attendants. Okay.
Actually, this point of yours is a new point for me as well, madam. I'll definitely go and will read and will try to bring out more evidences. We'll share with you and with others as well.
Yeah.
Definitely, ma'am. And the next question is, ma'am, CPAP Rajesh sir is giving a comment that CPAP delivers a constant peep, while HFNC cannot deliver a constant peep but a variable peep. I think
Yes.
yes,
Yes.
it's a useful comment in the press in this context. But we are not going to talk about pressure delivery devices in this talk, sir. So we will leave this for the next session.
Yeah.
Rajesh Kulkarni sir is adding a point that PEEP is more important in most of the cases. Point well taken, sir.
Yes. That's the crux of the respiratory distress in the neonatology. My presentation on oxygen delivery, so I have to talk about the oxygen delivery devices. But for the people who were asking that whether we can start with oxygen hood and subsequently think of HHFNC, not so. PEEP is always important. So all these devices like HHFNC and CPAP, it delivers the PEEP. That's why they help. So PEEP is most important. By giving oxygen supplemental, we are just increasing the oxygen level in the blood. We are not helping the disease. That you have to understand. And this should be the important takeaway. One should not be carried away with the name of the topic that it is oxygen delivery. The neonatology respiratory distress is about the taking care of the PEEP of the baby or FRC of the baby.
Absolutely. That is one of the most important points which I need to highlight by putting oxygen therapy in neonate as a topic, so that everyone knows that having oxygen in the setup will not equip that setup to handle a sick neonate or in neonate who might be needing more support. And utilizing oxygen alone without using pressure support is not the art of handling a neonate. You need to have a backup plan or an anticipation that if there is BEEP is the art of handling respiratory distress in neonatology. In fact, one of the question also in this is delayed adaptation in transient tachypnea of newborn. Probably this is delayed adaptation in transient tachypnea of newborn. In beginning, you don't know that this is only TTNB. So you again
Yes.
start with oxygen. You again start putting it with pressure. You start decreasing it immediately if your target saturations are achieved. But you help the neonate by giving them the relevant pressure support, and at the same time you provide them a relevant FiO2. So
Yes.
yes, definitely, ma'am. Rajesh sir is completing his question by putting a comment that Downey score ABG value should be taken into consideration. In continuation, he has mentioned that my message was not fully read. Probably I was not able to explain or express in the way he
I
wanted.
think they can be extended scoring, or there are various other scoring system. Conventional Downey score had 5 points, so they mostly that mostly said that whether it is a more than 40% FiO2 to avoid the cyanosis or less than 40% or baby is having cyanosis on room air. That was the only oxygenation aspect of the Downey score. So there, I think Dr. Rajesh must be telling about some
Extended.
updated Downey score or some other score which takes into account of ABG. That can be fairly well taken. The assessment of respiratory distress can always be done by all the means. That's
Yeah.
fine.
ABT will complement, but
Yeah.
you should
Yeah.
remember that it's an invasive procedure, needs a lot of skill set to do it in
No,
unit and lot of
actually, what is, I don't know about the others, but in our unit, we mostly do the venous blood gas for the mild respiratory diseases or mild to moderate diseases, and only resort to the arterial blood gases for the babies requiring advanced respiratory support, high frequency ventilation, or hydroxide therapy because of the need of the invasive arterial sampling. So, if you have to really go for the ABG, there has to be indwelling arterial line. So that is the unit that practice varies from unit to unit, but then it's up to individual practice. That is what I can say.
Rajesh Kulkarni sir is telling with a comment that everyone, if want to learn about
Yeah,
indigenous bubble CPAP, they can go to YouTube. And
yeah. The old the people who has worked 2 decades back are very well aware of the
but
indigenous CPAP, and we even
we as
know
a
that.
country is
Yeah,
yes.
please go ahead.
So use of nasal drop, etc. in neonatal respiratory distress when using ETO HHF NCQs.
Any use of nasal drop? No, no,
Any
no.
use of nasal drops in neonatal respiratory distress when using ETO HHF NCQ.
No, I
Probably
don't think so. The only thing is that you have to take care of the nasal crusting,
yeah,
or you have to take care of the nasal blockage. What is our practice is that with every 6 hours we look for the whether there is any
injury.
crusting or dirt or dust in the baby's nares, which is obstructing the flow of the high flows or oxygen delivery. So we do check for that, and if required, we put the nasoclear or saline, normal simple saline drops. But otherwise, there is nothing like that.
Other questions from Dr. Ramakrishna is about mention the condition where maintenance of sleep is very much required. I think, ma'am, we will take these questions all together when we start our sessions on now on oxygen therapy will be concluded and pressure devices will be starting. So all these questions, including the other question where monitoring or tapering of HFNC in short has been asked. So we will take this question in next session itself, ma'am.
Yeah, yeah,
Uh,
I definitely agree.
and Dr. P is asking, ma'am, venous pH, oxygen and saturation value according to your practice minimum, what should be the cutoff which we
For,
should
for,
rely upon?
okay, so for the as we do VBG, so SpO2 is like in venous gas, we are not just looking at PO2, not SO2, SaO2 or PO2, we are not looking at that because we are monitoring the oxygenation by pulse oximeter. So we just don't have a habit of saying that O2 levels in that. But pH is again the same, that it should be more than 7.35, and we don't look for the oxygenation in the VPG. We mostly look for the CO2, bicarb, and pH in that.
My next question is, as per your experience, Airvo 2 versus Airvo 3, which one is better?
No, I haven't used Airvo 3, so I would not be. In our part of the world, the service of FNP is very bad, so we are mostly getting away with the any Airvo. We mostly give HHFNC through ventilators or indigenous kind of setup. We have humidifier and blenders, and we just do the setup and do HHFNC. We just only need the interface, that is nasal cannula. That is it. I
I
haven't
would
used
like to
Airvo
add to that
3.
question that Airvo 2 versus Airvo 3, they both are good devices. We are using Airvo 3, and we have seen that utilization from neonatology till adolescent, which has a good usage, but definitely the cost will be there, and support of your management and yourself, if you're taking care of the expenses, will be there. But over and above, as our unit, we are happy with the
Uh, uh,
devices, and in fact,
Yes, all the this air FNP devices like Airvo 2 is very good. Matlab, I have used Airvo 2 and I would say that these the humidifiers, the HHFLC device, the therpay, all the things are very good. But then
yes,
their routine services are not okay. That is thing. Machine is there is no
yes,
problem
yes.
with the machine.
My one question is frequency of X-ray in HFNC or clinical monitoring.
No required. You can just do
Great.
one. Not very much. There is no role of routine X-rays. If the if there is a baby who just is just born, is having respiratory distress, or or the one who has been admitted to you, and you are not having an unequal air entry, you start the baby on respiratory support and escalate it. And if the baby is improving, just do one X-ray at admission and nothing more than that. I would say if there is deterioration, do trans elimination, do take care of dope, and if required, then consider for X-ray, not routinely.
And with this extensive discussion and with a lot of knowledge being shared, I would humbly like to end this session, ma'am. And thank you once again for taking out time and giving us your piece of advices, knowledge, and sharing your understanding of oxygen therapy with all of us, ma'am.
There is
Thanks a
one
lot.
comment from Dr. Rajesh that pulse oximetry reading can be misleading at times. So again, the pulse oximetry itself is a topic in its way, and the pulse oximeter is said as a fair weather friend. That means pulse oximetry is only reliable if your such oxygenation level is more than 70%. For less than 70%, it is not reliable. So that is also a very valid point. Uh, Thank you. And thank you, Nitin. Thank you very much for inviting me. Thank you.
Thank you, ma'am. Thank you, everyone, for joining. Thank you, everyone, for putting their comments and thoughts. Thanks a lot, ma'am.